are ready for another club webinar. It's number 69. Got a fantastic topic for you. Of course, I say that every time, but it's another really good one in my opinion. It's going to be about knee replacement surgery in medical coding, and we're going to look at all the code sets involved. We don't do that very often. We usually look at the CPT or we look at the ICD, but we don't look at CPT, ICD, and PCS all in one setting. Wanted to give you kind of an overview of what you can expect to see depending on where you work. And I might throw in a couple nuances about risk adjustment, but the fact is, procedures don't risk adjust, but the reason the person may need the procedure might. So we'll talk about that. Don't want to forget to tell you about the awesome CCO Club. It's real easy to find. It's at cco.us/club. I like doing that. I like saying /. I've decided at the Q&A webinar we had the other night that was one of my favorite things to do. So I like saying cco.us/club. That is where you will be able to get the handouts for tonight. Yes, we are streaming this live and you can come and visit us and watch and get the information there. But if you want the handouts or the slide deck and the transcript of what we talk about, as well as eventually getting CEUs when we get that all set up after the fact, got to go to the club. Plus, we can continue to discuss the topic. It's really easy to find. Again, what did I say? cco.us/club. Maybe it'll be a thing. And let's see here. The first thing we need to talk about is the anatomy. What is the anatomy for a knee replacement? I found some really good graphics, and I have to tell you, if you're squeamish, you might have a problem with a few of them. So just heads up. You know how I like real pictures. So the major anatomy that you need to be aware of when knee replacements are being done is, of course, the femur. That's the largest bone in the body, and that is the top part of the knee joint. The patella is the kneecap. And then you have the tibia. Now, the fibia is there, but the fibia is actually off to the side and doesn't actually touch the femur. It's not part of the joint. It's off to the side. However, the tibia does. So the head of the tibia is the same size, maybe a little bit smaller, than the bottom of the femur, the distal end of the femur. And you'll notice here, you can see how that's fitting together. I do have other pictures that you can see how that is side by side, where we have a front view, a side view, and a back view. Very important to understand the anatomy and where everything lays in a joint. Now, I'm not going to go into more detail here because I do have other graphics. Why do you need to know the anatomy? Well, first of all, it's going to be documented. And as you're reading the op reports, if there is any complications or they're doing maybe a revised knee replacement, which we're not going to talk about tonight, we're going to do just a simple knee replacement, then that would be pertinent. Also, you may or may not have known that you can have a total knee replacement or you can have a partial knee replacement. If you have a partial knee replacement, notice there at the head of the femur how it has two ends here on that back view. Well, that means they may only replace the one side or the other, the left or the right side, and I'm going to show you that as well. So it's important for you to know that the knee is actually the biggest joint. I was surprised about that because I thought that it might have been the shoulder. The hip, we think about the hip. However, the hip is a ball and socket joint. It's a different type of joint, but really, actually, the ball of the femur, that femur head, isn't that big, and it fits up in to this little cavity of the pelvis, which isn't actually as large as you might think. Now, of course, you have the pelvis comes out, but really we're just talking about the head of the femur. Unlike the knee, which actually, when you look at the femur here, we have two edges. So those aren't a ball like the ball and socket joint of the hip. It actually has two areas there that touch the top of the tibia, and they've got to line up really well. Also, it's one of the most often injured of the joints. It's very easy to compromise the joint in that it isn't meant to go more than just forward and backward, allowing the tibia to rock forward and backwards. But if you hyperextend it, or again, someone takes out your knee because you're roughhousing or something and goes off to the side, complications. It's really only being held together by tendons and ligaments. Now let's look at those tendon and ligaments. The one that everybody talks about is the ACL, which is actually the anterior cruciate ligament, which is that main ligament right there in the middle. Okay, that's the larger ligament. The patellar or the ligament going up to the patella, that is a large ligament, but it's just holding the patella in place for the most part. But the ACL is what sports injuries often happen. If you tear that, that's really holding the knee together to be able to rock and make that motion. Whereas you'll notice the ligaments on the outside, you have the medial and the lateral ligaments. So you have the tibial, medial ligament, and then you have the fibular ligament, meaning that the fibula is there's a ligament coming up off the fibula connecting to the top bone, and you have the tibia ligament, and it's holding those into place so that it doesn't, the bones that are on top of each other like this don't fall off side to side. And those get stretched sometimes they tear, but once they're all stretched out, you don't have good knee support. Another area to note is the meniscus. Now, the meniscus is not actually a ligament or a tendon. It's a cushy place, like a cartilage cushy place for the two bones to rest. And this is a funny way to think of it, but have you seen those commercials? I don't know if they show it anymore, but where they used to put like that denture grip type stuff. Think of it like that. It gives cushion, and it's shaped actually like that. I've got a picture of that. So bones, cartilage, ligaments, and tendons, you will hear them mentioned. And all of these words, all of these anatomy words will be in the documentation for a knee replacement. When you get your knee replaced, you don't need your ACL anymore. So they actually cut it. You don't need those ligaments on the side. Sometimes they leave them, sometimes they don't, depending on, are you doing a partial knee? But the fact is your new knee is secure, and it's not going to rock and move around. It's kind of like a bionic knee, I guess you could say. So all of this verbiage you will see in the documentation, and it's important to know what they are and also what their purpose is. Why do you get a knee replacement? Well, number one reason is to reduce pain and to improve function. This is a picture of somebody that has the osteoarthritis. Notice that I told you about that ACL ligament right there, but all around here, doesn't that look like denture cream? that is worn out, right? But this is a large cartilage. Now, the meniscus is what's on the bottom, but this is all cartilage that supports the end of the knee and protects it. That's what cartilage does. That's what's at the end of your nose, right? It's malleable and it's not really soft, but it gives you cushion. And it should be nice and shiny and smooth. However, this is what it looks like when it's been all worn out and also gets arthritis. I got a little picture of arthritis to show you, so you can note that. When they replace the knee, look what they're doing. Now, in this one, they've left this outer ligament, and you have a new meniscus, which is actually a plastic plate, and then you have this, which I don't remember if it's titanium or not, but I know they do titanium hits. So let's just say, for the sake, that this is titanium that's screwed into the end of the femur, and then the patella is just put back in place. You get to keep your patella, and then you see how nice and smooth that would be in comparison to this grating on the other side. Also, another aspect to see is that you see this little shadow area into the tibia. That's actually drilled into and placed into the tibia, so it can't be moved around. We'll look at that in another video here. Not video. So femur head, cartilage, tibia, fibia, arthritis, and patella are key words that you're going to hear also again and again in the anatomy. When they do a partial knee replacement, notice the difference between that and the total, and that's what it's called, total knee replacement. This patient got to keep the one side of the cushioning, and the plate is not on that side, right? In fact, I think they've kept their ACL. I don't quote me on that, but the ligaments stay in place. And then notice for the total, the ACL is gone. Actually, more of the ligaments and tendons would be gone, but those outer ligaments, they look to be in place. And you have the femur head is actually sawed off, and the new piece is drilled in to the femur head, and it's curved so it can have that rocking motion. Then you have the plate, which is the artificial meniscus, and then it's solid also, like a solid base. So if it's a partial, they're only replacing one side of the head of the femur. And if it is a total, then both of those curved areas will be replaced. A little more of a description of what the damage looks like and how they do the before and the after. Normal. See, the femur head has that. They've done this one in pink so it stands out, but you have the cushioning and the rocks there on the top of the tibia. But if it's damaged cartilage, it's going to literally grate and grind, and it's very painful. So you have a before knee and an after knee. Now this is a partial, and then you see how they grind down or literally saw off the parts of the bone that is damaged. So they take off the cartilage, and then they take off the bone, and then they screw those plates into the bone to replace those ends ultimately. Now you can see the difference. Look at an X-ray of the normal knee. Notice that space in between the tibia, or the tibia and the femur. And this is also where you see that they're actually the same size. When you look at pictures or you think about the tibia and fibia, I always think of them being so much smaller than the femur, and they are. The shaft of the femur is much larger, than those bones. But the you see here also how the fibia doesn't actually come up into the joint. It stays off to the side, but there's ligaments holding that in place and attached for stability, the top, that head of the femur. So we have nice space wherever there's air. Of course, you're going to see that as a dark line. Now look at what happens with the arthritic and the worn out knee joint. It's laying literally on top of it. So it's bone grinding on bone with no cushion left in between. And that would be like a person trying to wear their dentures, but after they had taken their dentures out, ate popcorn, and then tried to put the dentures back in, and then eat an apple. That's what I would think it would be like if I could compare it to something else. Oh, let me go back. I forgot to show you. This right here is actually a view of the inside of the joint. And see this bottom that looks like fur sticking up? That's arthritis. That's what arthritis looks like. And my son, I talked about my number 4, and that he has juvenile arthritis, and they found it in his knee. And his arthritis was, the doctor said it was so bad once they got in there and scoped it, because it didn't show up on the x-ray, it didn't show up in the MRI, but it was so bad that he said it just looked like sea amoebas and anemones all over the inside of his knee. So this is just a quick little view. You can go in and see pictures. Just Google image knee arthritis, and that is just one that I liked, that view. Sometimes it's not real hairy looking, but real thick and spiked, like crystals growing up out of the joint. And again, you can see how painful that would be. Continuing on with the anatomy. Now, this Dr. Grossfeld, the article that she wrote, really, really good. And I also want to iterate that this isn't all the information you need about a knee replacement. I am going to whet your appetite with it. I'm going to give you the information you need and then allow you to do further study. So it's a launching point and give you the basics, the stuff you need to be aware of, and the codes that you'll be experiencing and using. And then you go out and do additional research. Hopefully this whets your appetite and you think, wow, this is really fascinating. Now I'm going to go look at hip replacements. And then they even do ankle replacements. I think they don't like doing those as much. Or no, I don't think maybe they do ankle replacements, but I think they fuse the ankle sometimes. Anyway, go look into that and some of the other orthopedic procedures that are done. Dr. Grossfeld had an amazing article and has a really good website. And I've linked all the links that I looked at in the reference page. So again, if you're watching us live, I'll show it to you. But if you're in the club, then you can go back and you can look at those links and you can actually link off of those and read the articles that I got this content from. Not all of this came off the top of my head. Some of it did, but not all of it. The image here, this first image, is what a normal knee cartilage is supposed to look like. And she states, white, smooth cartilage that covers the head of that femur. And then the next picture is one that has arthritis all over it. So instead of it being that nice, pretty color, you have this white arthritis, which is irritating and painful. And, if you really got in there and looked at it, it probably has that hairy look to it. Then the procedure that is used sometimes to help with arthritis, if they don't need a total knee replacement, is they go in and scrape at the arthritis. They don't scrape it off completely, but they scrape at it and get down to the bone again. And then they put holes and scratches and scrapes in to the bone itself until it bleeds. So think of it as like tenderizing a steak. Okay. But they want to put why are they wanting to put that damage in there? It's because it releases the blood that has the stem cells and other areas, other components that heals that knee joint. So think of it as scar tissue, and scar tissue is better than arthritis. It may heal and give a little bit of cushion so that that patient has a little longer to go before they have to have a knee replacement. That gives them relief for a while. Sometimes it works really, really well for a long time, and other times it doesn't. So they're scarring. It's gonna like making a scab on top of where the arthritis is, so it cushions for longer. Thought that was really interesting, and it gave you a good view. So here we get into some pictures that may be hard for you to look at, or maybe not, I don't know. But let's identify. I went ahead and overlaid arrows on this picture so that you could see what we're looking at. The first arrow here, and I don't know if you can see my cursor or not, but I'm going to run my cursor around it, is showing you that's the head of the femur. And you see that it is not there are areas of it that is pretty and has a nice look to it, nice shiny look to it, an area, but this is all arthritis, all of that around here. This is where they've worn completely through the cartilage, and look, you can see it even almost looks like it's bruised, or where it bleeds a little bit in there. Now this is the ACL right there. This has arthritis all around the knee, and then come around here to the other side. This is actually the head of the tibia, and this black stuff is could be arthritis, or just where they've burnt a little bit or scraped already. I'm not sure. You can see pictures like this on Google Image and see different amounts of damage to the knee. But this is a great one that shows you how this right here is just the normal fat that we have around. This is all arthritis, literally clinging to the joint. So they've opened it up and pulled it apart and separated it. So at this point, the knee is bent. Okay, we're looking at it, and we want this nice and slick so that it rocks right here. And even this looks porous and unhealthy. Time for a knee replacement. And this is kind of mid-range. I asked the doctor, and the surgeon said, yeah, she's seen worse, and she's seen better. Not as much damage as this. So this is pretty mid-line damage, which again, pretty painful at that point. Now back to anatomy. We've gone over the basic structures, but the reason this one really stood out to me, and besides the fact that I love Find a Code, is that it shows all the bursa, all these bursa areas, and that is something that you hear in the documentation that you don't usually talk about. We talk about the bones and the ligaments, the meniscus, but the bursa is actually commented on a lot when you look at the documentation. So I wanted to bring that to your attention. The back view of the knee, again, look at the bursa and their individual names, because you will see that they are defined. Now, all of these internal type ligaments and things, they don't, when you get your knee replaced, you don't need those anymore. Here is another reason why I think the meniscus is like the denture cream for the knee. It even has a curve like the dentures in your mouth. So this is called the anterior medial horn and the anterior lateral horn. Media means close to the center of your body, and anterior is the away from the center of your body. So that way you would see that the medial would be closer to would be on the side of the big toe, and the lateral would be on the side of the little toe. Very easy. But doesn't that look like where you could just plop some dentures right there? And that's the meniscus horns. More verbiage to be aware of. When you look at an op report, what is the different portions of the op report that you're going to see? First thing you know, that when you have a total knee replacement, the patient's going to be under general anesthesia. Now, you're not going to see anesthesia codes in the op report because the anesthesiologist has their own report. It will state, the surgeon's report will state that there was the anesthesiologist and who the anesthesiologist was that was caring for the patient, but really that and what type of anesthesia was provided. But that's the extent that you'll hear of the anesthesia, unless there's a complication that makes it to where you have to stop the procedure or so on and so forth. Any type of complication would definitely be an indication that the anesthesia information would be there. General anesthesia, oops, sorry, bump that. General anesthesia. They also often do, or can do sometimes, a spinal epidural instead of the general anesthesia. Now, there would be some reasons why they would do that and they wouldn't do that. Different surgeons, want their patient completely under, and some, it really probably depends on the age, if the patient is an athlete versus, a geriatric that's getting their knee replaced. But one of the things they absolutely do nowadays is they do a knee epidural. So right above the knee, they do, it's not a block, but it is an epidural where they numb everything from above the knee joint. And not only does this help with the pain of the procedure during the procedure, as well as the general anesthesia, you get both. It's going to also give comfort after the procedure. Because think about this, we're not only breaking the joint, we are sawing the ends of the limbs off. And I've got a picture that signifies that. So you can imagine how much pain a person is when they break a bone. We're traumatizing the knee, we're manipulating the knee, we're picking it up and moving it around, and so not only is that painful and all the nerves are inflamed and angry, but you're going to have swelling and the muscles are going to ache because it's being manipulated roughly. They also use the same tools you may use to do improvements in your house. It is literally like one of those DeWalt drills that you get at the hardware store, and it was pretty interesting. So they do a vertical cut. The verbiage that you see here is typical because you have to explain what you're doing step by step, and it's usually 8 to 10 inches long. They'll talk about that. They move the kneecap off to the side so the patella is moved off to the side, and then they go and remove the damaged bone and cartilage, and they'll explain the equipment that they use and how much is taken and measurements that are taken and so on and so forth. It's actually pretty fascinating because now with the MRI, they make a plate guard personalized for that patient, and they attach that onto the end of the femur, and it has a little hole in it like this, and then they stick that drill in there and slice that bone off. So it's literally measured and made for that patient, and then it's thrown away because it's individual. And then a lot of times they'll go ahead and remove the ACL, sometimes the PCL as well. But the outside ligaments are kept intact. Verbiage also, we keep saying knee replacement, but the proper verbiage is total knee atheroplasty. So, because plasty is repair. And so TKA, you'll see TKA. And then if it's a partial, it's called a PKA. So it's any type of knee arthroplasties. This is a before, well, no, it's not a before, it's a left and right view of a person who's had a knee replacement and a person who hasn't. Other types of knee replacements, if they do outpatient knee replacements, common verbiage is rapid recovery knee replacement, same day knee replacement, and ambulatory knee replacement. But ultimately, the goal is when they say this type of verbiage, they're getting you in and getting you out on the same day. Now, sometimes they may do outpatient, but they keep you for observation just to make sure you go home the next morning, to make sure that you have good pain control before you go home, and that you're able to articulate and move that joint and without any problems, that everything's working together well. So that's another reason why they get you up immediately and start you moving around unless you have complications. So they want you to be able to go home as soon as possible. I listened to, well, I watched a video of a knee replacement done in February, and the two surgeons talking about the procedure. It was the first time they'd actually filmed it, and then they walked you through it afterwards. They don't like talking while they're doing it. I mean, it's like, you have to really concentrate with what you're doing. You're working with power tools, and so they were going over everything that they were doing, and then they spoke about the patients that did the best were the ones that were able to get home right away, do their recovery at home. They got to sleep in their own bed. They got to eat their own food. They had their family, or caregivers taking care of them. And they just overall felt more comfortable, and they actually did better, had a more smooth and quicker recovery. So I thought that was interesting to note. So you see that trend, get them home as soon as they can, get back to where they're comfortable so that they can start doing therapy. That's really, really key. Another bit of documentation that I felt that was really important to understand is some information that cms.gov gave on descriptions. If you want your procedure to be paid for, then again, we need to make sure we're using the proper codes for the procedures that's being done, but we also want to make sure that medical necessity is being met. CMS is very, not critical, that would be the wrong word. They are, it's essential that the right documentation is used to prove medical necessity, meaning we need to know what's going on with this patient. And this came straight from cms.gov. It said for the TKA, we need to know which effect the function of the joint is being affected, and also there could be known as revision, total knee, revisional surgery, the placement, the components, and if there was a previous surgery and it was a failure, then so you might see a revision of a TKA. All of this verbiage is important to understand because it means there's different codes. The goal, of course, is to give pain relief and improve functionality, which we kind of mentioned that in the beginning. So history of other treatments that have been used have to be documented, not in the op report, or maybe they will say that, they went through therapy XYZ and therefore we're doing a TKA today, but leading up to the point of the TKA, all of this needs to be documented so that if the patient is a Medicare patient, which probably most TKAs are your Medicare patient, because a lot of this is just age related, that they want to know, is it trauma related? Is it age related? What's the history? Does the patient have osteoporosis? Does the patient have osteoarthritis? Do they have other comorbidities that have caused problems like pain in their back because they're not able to walk, et cetera, et cetera. In addition, they stated in CMS that legible procedure notes, of course, we all know that, but it has to be sufficient detail to allow for reconstruction of procedure. Now, if you've ever read an op report, and they literally are going step by step what they're doing. You think, why are they so detailed? Why are they telling you all this stuff? Which, as a coder, it's mostly fodder. We don't care about all that stuff, because we need to know what procedure was done, the description of the procedure, if there was any complications or changes, if it, the whole procedure was completed, they didn't have to stop for any reason because you might have to use a modifier and stuff. And that's what we're looking for in the documentation. However, that's not what is necessary. You have to be able to read that and reconstruct the whole procedure from start to finish in somebody's mind by just reading it. That's why they're so detailed. Patient's conditions before, during, and after, and is also showing medical necessity has to be provided. History and physical, that means office visit notes, emergency records, progress notes for nurses, treatment records, consultation reports, and any other pertinent medical records. All of that is encompasses getting reimbursed, getting the patient first to be allowed to have the procedure, because if their insurance is going to be paying for it. Also, pain history has to be noted. Functional disability, where you can't go from your bedroom to the bathroom without having an accident, because it takes so long and it's so painful to get there. So that's one. Was it due to trauma or arthritis? Then it wraps up about getting approval. We need to know that pain interferes with the ADLs, that it's increased with intention of activities, and increases with weight bearing. Those are the three biggies when it comes to pain, that you've gone through every other process. You've used medication, you've used therapy, everything you can do, and nothing else works. Now we're to the point where we're just going to have to replace the knee. Now let's talk about the codes. Yay, we're going to start with CPT codes. The main codes to be aware of, and we used the BAT technique which you would do in your manual. So if you're following along with your manuals, or if you're in the club, you could do this later, you can come back and reference this. You would look at the code after the semicolon. You're going to highlight everything after the semicolon, and you're going to underline anything that makes this procedure different from the one above it or the one below it in the sequence of codes. The main code 76446, atheroplasty, because that's what we're doing, an atheroplasty of the knee, condyle, which is cartilage, and plateau, medial or lateral compartment. So this is a partial knee. You're going to either do the medial, going up from the big toe, or the great toe is what they call it, so the inside portion of the knee, or you're going to do the outer portion of the knee. One or the other, you're not going to do both. So this is the code for not a TKA, but a PKA, partial knee arthroplasty. If you do both the total knee, it would be the 27447. And again, notice that the verbiage is all the same up to the semicolon. Then it says medial and lateral compartment. So that's why that's highlighted. You have to see that the 27446, it says medial or lateral partial. 27447 is medial and lateral compartments with or without patella resurfacing, so we don't have to worry about that. This is considered a total knee atheroplasty. So that, if you total knee, that's your code. In addition, if a computer was used, 20985, that's computer assisted surgical navigation. Now this is imageless, so you would list this separately and you would do the primary procedure. I keep hitting the camera and I apologize for that. 27447, and they did 20985 because the surgeon had a computer to assist. So what is 27446? Again, medial or lateral compartment. Or what if we just did a revision? So the total knee had already been done. And they said, is it with or without an allograft? One compartment. So again, 27446 is a partial knee replacement. So it's the same, it's copied from the top. So don't think that this is a different one. So if we did a 27446, and then later there was a complication, we needed to do a revision, and they're going to put an allograft in one compartment, either the medial or the lateral side. 27487 is femoral and entire tibial component. And that would be, don't worry about it being an allograft. So the allograft isn't pertinent there. It's the fact, did you do one compartment or did you do a femoral and entire tibial component? Then again, wrapping up with 27488, removal of prosthesis, including total knee prosthesis, and a methylmethacrylate, I don't know how to say that, with or without insertion of spacer in the knee. There are different reasons why they have to remove the prosthesis, but they have to put something in its place. So they maybe an infection and they had to go in, clean the knee up, take that apparatus, the prosthetic out, redo the bone and put a new one in. ICD. How does ICD work with this? Well, if a person has osteoporosis of the knee, primary bilateral osteoporosis of the knee, M17.0, one code. But notice if it's unilateral, so they did the right or the left, that is M17.1, but then you have to have an additional character, so that's why you got the space bar. Unilateral, meaning one, primary osteoarthritis. Is it of the unspecified knee? We hope not. Or right or left. So if they do the right knee, it would be M17.11. They've got osteoarthritis of the right knee. Notice Z96.65, presence of artificial knee joint. And the last character there is going to be either 1 for right, 2 for left, or 3 for bilateral. Z47.33, aftercare following explanation of knee joint prosthesis. And again, that may be a code that you'll be using whenever the patient's having a TKA. What about our PCS codes? We don't talk about them enough, and I love the PCS codes. If we do well, first let's look at the little green box down in the corner. We know we're going to be doing med surg. That's an O because we're doing a surgery. And this is where lower joint, that would be an S. So then they want to know what you're doing. You're replacing something. So it's an OSR. All of these you notice are OSR codes. Every one of them, because it's med surg, lower joint, or lower joint, and you're replacing something. So then notice that we need to find out, are we doing the right or the left joint? Because if it's the right, it's a C. If it's the left, it's a D in the next field. What if you're doing both? Well, there isn't a bilateral code here. You're going to list both codes. That's how PCS works. And then you have OJ 9 for open approach. And it's cemented. Okay, so I underlined that. How did they do that? So actually what they do is when they cement, they use this cement, and it almost looks like a cookie, not a cookie punch. Doesn't look like a caulk gun. It looks like if you make those little fancy butter cookies and you push it and squeeze it, and you can make a little pretty thing and punch it out because it's clear. But there's cement in that, and they will put that on there, kind of like when you're putting two bricks together, right? You know, they want that to seal. So it's going to be screwed in, but it's also going to have that cement in there. So if they use cemented, then it would be a J, open approach 9. If they are uncemented, and then also you have replacement of right knee joint, open approach, not using any other information, but that's the right knee joint. And then replacement of left knee joint, open approach, uncemented. So these are the codes. If you are not sure, all you have to remember is you got to go to OSR. When you get to the PCS manual and you go to OSR, everything else is going to be in a table, kind of like a drop-down table. And you just literally move your finger and fill in the blanks. So simple. Now, I also wanted to iterate because I found this information that's in this lower, the smaller, is also in the resources, because it was a great outline of working through the process. It said, currently there's no way to code for medial or lateral uncompartmental knees. So it says option 1, do not differentiate from unilateral or total knee. And then it says option 2, you can add B for cemented uni, C for cementless uni, of the 7th character. In other words, what if you cement one knee and you don't the other, right? And you're doing both knees? Because some people do get their knees replaced at the same time. Wow, I think that would be incredibly painful. Open approach, or option 3, add L for lateral and M for medial for the 6th character. Also, there is not a code for a patellofemoral atheroplasty, and then they give you the right and left code. That is a OSU code. OSU, not an OSR, but an OSU. So I thought you'd appreciate having that. Spend some time in your PCS manual and look those up. Once you get the first 3 characters, the rest is easy. And in summary, so this is another view, although flipped upside down. This particular picture, that is upside down. This because of the head of the femur. And then this other picture is after the bones have been sawed. So they sawed off the end of the femur, and they also sawed off the end of the tibia. And notice the large bore hole so that it can be placed down into that metal plate that goes into the tibia. So this is the tibia down here. You notice this is the end of the leg. This right here is the, I'm sorry, I'm saying that incorrectly. This is the tibia. This is the femur. Because notice there's the end of the leg. So this is upside down. And that bore hole where this piece, because it's a total knee replacement, is cement and shoved in there. Okay. And then they do the same thing, although it's actually a bigger hole there. And then they take a mallet and they bam, 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 right in there. Now, if your patient has osteoporosis, that's kind of a good thing, because if their bone's not super dense, that'll go bam, bam, bam in there real smooth. But if they don't, if they have dense bone, then man, that surgeon has to really hit that mallet and bang, bang, bang that into the bone. Think about trying to put a peg cut a tree off and then try to put pegs, drill holes and put pegs into wood, I guess. And so this is what the knee looks like. Notice again, it's upside down, but it's the view of the surgeon. I guess I could have flipped those. This is the head of the femur. This is the head of the tibia. The meniscus is removed. So this would be like the artificial meniscus. This is the artificial, this little nub sticking up is the artificial ACL that's holding everything together. This joint isn't going anywhere. It doesn't need those ligaments to hold it in place, and it doesn't need cushioning anymore because it's not electronic, but it's manual. It's not computerized. Gosh, I don't know what you'd call it. It's bionic, although that would mean that it had like a computer in it. And that's it. I'm going to look here for some questions. It says, thank you, Beth. And thank you for the CIC perspective. So much more enjoyable than CBT. I agree, Alicia. Not only do we have the same name with the same spelling, but we also think alike. And let's see, osteoporosis means that the bone is weakened. It's spongy. It should be dense, but it's spongy and got holes in it. So in other words, your bone should look like a wooden block, but if it looks like a sponge that you clean your car with or you wipe down your kitchen with, it's not as dense and it easily breaks and fractures. All right. So Eureka says, thank you so much for the webinar. I understand more about the knee replacement. Knee replacements are done. I wish I had pulled a statistic on how many are done. You know what? You could do that. You guys go and look and see how many knee replacements they do in a year. Don't do 2020 because, again, that they had to stop during COVID for some of them. But go back in like 2019, see how many knee replacements that were done. It seems like younger and younger people having knee replacement and hip replacements. That could be true, but I did ask the surgeon, I said, that took these pictures, I said, how long is a knee good for? I said, isn't it longer than it used to be? And she said, no, you're still looking at 10, 15 years. But if you're in your 70s or 80s, how long are you going to live, right? So it should be good. But if you're younger, absolutely, yeah, you could end up having to have it replaced or revised, right? That's why those codes are there to be used. Thank you, Beth and Cecilia. Thank you, guys. Appreciate those kind words. If you're in the club, carry on the conversation there. We'll keep talking in there. These are the resources that I used. Lots of really jam-packed information. I would love for you to go out and check those links out. Also, if you find anything that's pertinent or helpful, put it in the club. I would love to, or even if you've got some op reports that are redacted that you could share, that would be excellent as well. And then we could talk about what makes one different than another. Difference between osteoporosis and osteopenia. Well, I'll tell you what. Go look up the suffix penia and porosis or osis, and it'll tell you the difference of what osteoporosis and osteopenia is, and it is two separate things. Gotta learn. Gotta love research, right? All right, guys, we did it. And if you have a particular topic, if you're in the club, let us know. If this was helpful for you and you liked this format for the club, let me know and we'll do another procedure. I would love to do research. This was a lot of fun. And we don't, I'm really an ICD gal. So, I have to work a little harder for the procedures to research and get that information, but I enjoy doing it because it makes me smarter. So let me know if there's something out there that you want to know about. We'll do it in the CCO Club because you can go to cco.us/club. Okay. Bye, guys.